Dr. Suleiman AlhabibCenter in Riyadh. Dr. Owayed is Chimmery, the intervention cardiologist, and with him, Dr. Colin Hansley, intervention cardiologist from Mantle Private Hospital in Dublin.
السلام عليكم خالد.
Assalamu alaikum, Owayed.
هلا حبيبي.
Welcome to
Thank
the...
you, Khaled.
Can you hear us, Owayed? Huh?
Yes, I can hear you very well.
Good. So we can see you, we can hear you. Go ahead with your case. We have half an hour before we go to prayer.
Okay, I'm very honored and pleased to work with Dr. Colin. He looks much younger than he is. And I have my team here in Riyadh, Babs, Ola, Muhammad, and Anna. So we'll go to the case. Next. Go next, please. Okay, so I have a 49-year-old who admitted to the hospital with atypical symptoms, together with 30-minute transit anesthesia. He's found to have an elevation high, as troponin was 80 and our normal value is 15. He has passed his diabetes for 15 years with reasonable control of hypertension for the last 2 years, not in medical care. He has also dyslipidemia. Next. So, next please. So when he admitted, the blood pressure was very high, and with this transient anesthesia, it can lead to hypertensive emergency. The MRI was normal. The EKG has horizontal distribution lateral leads. Echo multiple otherwise normal. He has renal duplex ultrasound showed high increased the peak systolic velocity to 140. This suggestive of stenosis. So we decided to do coronary angiogram and choose his renal.
Wait, there is echo. Wait, there's an echo in your voice. I don't know. The technical guys can improve the.
Did we-
Same as yesterday. It's the same as yesterday. It's because the speaker's on in the lab that you're getting a feedback loop.
Okay, so in your side, they switch off their mics.
If we switch, can you hear me okay, or is it?
No, I mean their mic. They switch their mic in order to hear us. Very nice. Okay, Khalid, do you understand what we have said so far?
Yes. Go ahead.
Okay, see the angiogram. It's better to go to this angiogram today. Like it now. Yeah. Okay. Now, do you see that?
Yes, we see the right coronary artery. Go ahead.
So the right coronary artery there is, as you see, a small size PLV with borderline disease. The BDA has a different branches. The upper has more diffuse, the lower has focal. So
So there's actually a significant lesion in the circumflex and a significant lesion in the LAD, which we haven't shown you. So we thought this was a syntax 2 type case with multi-vessel disease, which is going for cardiac surgery.
Wait, we cannot hear Column clearly. Can he adjust the mic?
okay, so call the speaker for the mic inside.
No, but I can't make out my.
Okay.
Is that better if you can hear me now?
Do you hear Khalid?
Yes, go ahead.
Can you hear me? I don't think you can.
Do you hear Dr. Colin?
Not clearly, really. The mic is far from him.
It's not working. They can't hear in the auditorium.
So why they hear me and they don't hear him? I have a mic?
Yeah.
No. Yeah.
Same as yesterday.
Okay. So
You do all the talking.
okay.
They'll understand you.
So Khalid. So because this patient has multivessel disease. The LAD, left circ, BDA, PLV. The syntax score is 13. Let's consider all of these. So whether we do medical therapy or not medical therapy, I mean physiological guided multiple PCI cabbage, so to diffuse cabbage, and we opted to go, as you see right now, that we are going to PCI. So we
Yeah.
started the procedure with the
Wait, can you show us the lift
yeah,
system? We just saw the right coronary artery. We saw the proximal vessel. There is no significant disease. Distally
sure,
might be there is disease, distally diffuse disease
sure.
in the BDA, maybe the BL branch, maybe in the other view will be better. But we like to see the lift system. You
Yeah,
mentioned he has three vessel
this is the left
disease.
system, Khalid.
Okay, good.
This is the left system. The proximal LED is patent, and as you see, the OM has a disease there. Go back, Bujana. So here is the OM disease, focal disease, and the caliper is a small size caliper. Next.
Yeah, so we've got multivessel coronary disease, and as I said, if he was going for surgery, he would get 4 grafts. This is a syntax 2 type case where it was mandated that you did physiology of every vessel prior to any intervention. Can you hear me okay?
Yes, we can hear you. So if I can summarize what we can see from the angiogram and we can run by the panelist, we can see there is a focal lesion in the mid-LAD after the diagonal, focal lesion. I'm not sure if there is another disease in other view. We saw focal lesion also in the mid-circumflex and the distal lesion in the BDA or the PL branch diffuse disease. Am I right? That's what we saw here. Is that what we saw or is this more than that?
No, that's it. That's correct.
That's correct.
Okay, can we ask the panelists here what we think before you're going to proceed, or here? Any of the panelists can comment?
Well, I mean, it's difficult to hear, and obviously a non-STEMI, so the question is, what's the culprit? What's the most likely culprit? And I think it's hard to see on this angiogram. Clearly, the most severe looks to me to be the mid-LAD. But I'm not sure if there were EKG changes that help you. And it's also interesting that he presented with transient amnesia. It's unusual
I think it was a type
presentation.
2 episode, Tim. I think it was a type 2 cardiac event, which subsequently led to coronary angiogram and multivessel coronary disease.
Do you hear us, Khalid?
Yeah, but we didn't answer the question. Do you think which is the culprit here? Did the ECG help you? Where is the culprit here in this? That's the question.
That's what we're saying. It's not a culprit. This is a type 2 troponin leak because of the hypertensive crisis. So it's like a positive functional test rather than a plaque rupture.
The culprit may be in the renal artery column, eh?
Exactly.
James, go ahead.
Yeah, I mean, he's presenting with profound hypertension and probable renal artery stenosis. So that may be your culprit, but the disease, the coronary disease, doesn't seem to correspond with symptoms very well. So then you're into that discussion that we had in the first case where you've got bystander disease. What does that mean in terms of prognosis? What does it mean in terms of symptomatology in somebody who's diabetic? Those are questions that we're still wrestling with, it's fair to say. And I think if you're going to progress here, I think physiology is definitely part of that understanding, may help you make decisions, but certainly the right is very distal disease. It's unlikely to correlate that with any sort of symptomatology. The LED, as Tim said, is maybe more impactful, and I'd be interested to know its translesional gradient there. Mervat, did you have a comment?
So the latest European guidelines upgraded both physiology and imaging in PCI, and I think imaging we tend to reserve for the complex cases, which is actually what the European guidelines are suggesting. Long lesions, CTOs, etc. I mean, these are focal lesions, so I'd ask the operators in the panel, what information are we going to get, additional information from imaging as opposed to physiology?
Owayed, did you hear Mervet's question?
Yeah, yeah.
Okay, so syntax 2, we did physiology at the baseline to decide whether we should or shouldn't treat a lesion. And then the imaging told us whether we had done a good job. Now, I do take the point that the physiology will help telling you you've done a good job, but they're telling us different things at baseline. So we thought this was a syntax 2 case and multivessel physiology because if he went for surgery, he would get a graft, certainly onto that PDA, possibly that PDA sub-branch if you've got a good surgeon. And if you go forward to the left views, he would definitely get a graft onto his circumflex, and he would get a graft onto the LED. And we know from syntax 2 that whenever you did physiology, a third of the time you did not need to graft all the vessels you thought you needed to graft. So that was our approach to this case. So one, and then we'll go back to the right. We started with the right because we thought that was the area with the most debate.
So calm, Carlos here. So there are a couple of comments here. The first one is that this is a patient presented with a non-STEMI. And I think we have to be careful in the use of physiology in the context of acute coronary syndromes. In this case, I'm not worried at all because the troponin is very low. That basically means that the amount of microvascular damage, edema, etc., is very low. So you can trust your physiological indexes. But if this was a case of very high troponin with a non-STEMI, there is no role for physiology here. Physiology might be abnormally normal because the microcirculation is not working in this acute phase. So that's point number one. Point number two, I think that this is a straightforward case, except if you have a translation of pressure gradient in the ostial circumflex, because that becomes a left main PCI. So what I would do is use physiology, do a pullback in both vessels, understand where is the extension of the functional disease. If the circumflex osteon has no pressure losses, go for PCI. If the circumflex osteon has a big pressure loss, then it will change completely your approach.
And that was our thoughts exactly, Carlos, and it'd be interesting in terms of, we started with the right because we thought that's where the most area of debate was. And if you go forward, this is the volcano wire, which is used in syntax 2, and actually a very excellent wire in terms of crossing. So go forward to the next lesion. So we're going to play the IFR. So this is the volcano wire going into that subtotal PL sub-branch or PDA sub-branch. So go back one. So yeah, don't show the answer until I,
Yeah.
answer one. So the IFR in that branch was 0.39. Okay. We then went to the PDA, and we got, if you go to the next one, so it's a really nice wire, this, in terms of wiring the sub-branch next. So we got an IFR of 0.90, 0.92. So we did adenosine, give adenosine, and did an FFR. And if you go to the FFR, we got an next one, FFR of 0.87. Show the FFR, yep. So no, just go to the one above that.
And he had a heart block with it.
Go the one above that, 0.87.
Above that. All right. Good. This is it.
So the right disease is basically physiologically, it's that sub-branch of the PDA. The main PDA, it's not ischemic, and we can discuss what we do with the right. So any thoughts, comments on that? The diagnostic angiogram of the right.
Yeah, I'll give you my thoughts on the very low IFR value. I cannot see the curve, but let's assume that the curve are good. I think if you have an IFR of 39, that basically means that the amount of flow that goes to that vessel is a lot. Otherwise, you would not have such a great pressure gradient. So basically, I was initially with the angiogram inclined not to touch the right coronary, but after seeing the physiology and the fact that it's very low, that basically means that the mass subtended by that branch is large. So I kind of changed my mind now, and I would treat the right coronary in this particular vessel.
And while it looks like a small branch, it's probably underfilled, isn't it, Carlos? And the physiology says it's quite a significant stenosis. So our intention was to treat that, but because of what we want to do here in terms of, we don't want to be putting loads of stent into 49-year-old diabetic, we're thinking of a DCB strategy, and we thought we would leave the right live and do the right offline, if that makes sense.
So wait, what is this now, the IFR of 0.39? This is in the BDA, am I right? Okay.
No, that's in the sub-branch of the PDA, the branch above it.
The upper bifid branch of PDA.
Okay, there's two branches, one the BDA. Okay.
The upper one. So there are three branches right now. PLD, upper bifid BDA, lower bifid BDA. Or the smaller BDA and the larger BDA. The smaller BDA is significant.
So by way of summary, the upper branch of the PDA is markedly ischemic, IFR shown here, and
Yeah.
the lower branch was non-ischemic based on the IFR. Is that correct?
Yes, that's correct.
Okay, tell us what you did. What next? You did IFR to the circ and the LID, or what next?
Yep. So IFR of the circ, what do you think it's going to be? Panel, any suggestions?
So this is the left circumflex. What we see.
Yep. What do you think the IFR is, or the FFR?
Colm, your mic is a little bit quiet. We're having a hard time hearing you.
Sorry.
Okay, so what do you think the IFR in the left circumflex?
Yeah,
Significant or not?
there is only two conditions where hyperemia is mandatory, and these are focal lesions in non-LAD vessels. So if you have a focal lesion in the circumflex or in the right and your IFR is negative, you have to induce hyperemia.
Okay.
Well, the IFR, if you go to it, was 0.53.
So,
But honestly,
Carlos,
angiographically, the circumflex is significant lesion angiographically. So this is not correlate the IFR with anatomical now.
and what is the mechanism
No,
behind the non-focality in the circ on the right, Carlos? Because my understanding is that your false negatives with IFR are much more likely in focal disease, irrespective of the vessel. Why does it matter more in the right and the circ?
So the reason why you have focal lesions having false negative resting physiology is because the mechanism of pressure losses in focal lesions is recirculation of the blood at the exit of the lesion. Think about that as a turbulence at the exit of the lesion. To have turbulence, you need flow. And the right and the circumflex, because they have low mass, the resting flow is low. Then you need to accelerate the flow to see if there are pressure losses. So this is an indication to do FFR, especially because it's negative. If it was positive, there is no conundrum. But because it's negative, you have to go to hyperemia.
You did hyperemia and
So
the.
No, Khalid, the FFR is 0.53.
Oh, point.
So significant. This is the baseline.
That's exactly the
the
point.
LED?
So I think it's if you want to stop the live case here, that'll be great because that's the message of the day. But you see this big discrepancy, especially in these type of lesions.
Yeah, I would have predicted offline that the circumflex may well have been negative because it looked to be such a small vessel, and often the circ can be surprising, but a resting gradient of 0.53, we have to treat that. And then actually, no surprise, the LAD, if you go to the final one, the resting gradient was 5.0. And it's interesting, the volcano wire allows you to wire all these lesions. It's a lovely wire. You know, I think the other wires would struggle to get through this sort of anatomy. And it's very easy to reuse the wire. So that's the resting gradient in the LAD. And in fact, we're working on the volcano pressure wire for the LAD. So just in terms of, so we have focal disease in the LAD, focal disease in the circ, and diffuse disease in that sub-branch of the distal right. I'm going to ask you in terms of who would put stents in, which vessel would you stent, and which vessels would you DCB, bearing in mind a young diabetic gentleman.
So this question to the panel here, the management-wise.
Well, I still think it would be helpful. So I completely agree with you about the circumflex. PDAs and the LED looks most severe. I still think it would be helpful to know if we knew what the culprit was. Because I think that would, especially the circumflex looks hazy to me.
It's not a culprit, it's a type 2 event.
Yes, I think it'll be difficult in this presentation and this case to identify which is the culprit.
Yeah, and the question from Mervat now becomes important. You've defined that there's ischemia in all three vessels, and you're trying to guide your revasc strategy. Now you need to understand the plaque morphology and burden, and that will help you guide whether it's a short stent, long stent, DCB, in terms of what you can achieve from that. And angiographically, we know there's a lot of gaps here. We don't really understand the disease at all. We can see the stenosis, but we don't understand anything else about it. So I presume you went to imaging at this point, Colm.
Yeah, Colm, one other question I had, there's been a progression of the use of resting IFR pullbacks to map out the physiologic lesional segment that maybe the angiogram misses. And so, we often know that angiographic focal disease, you may have pressure drops elsewhere that the angiogram's not showing you. So some part of it, if I put the wire down, I'll do a pullback just to make sure that the focal disease I see angiographically is indeed focal physiologically. And I think that also helps to at least temper my use of DCBs, acknowledging that DCB use in the US where practice is new. So we rely on the experience of people like you that have had it much longer. But if they're focal lesions that respond well to an image-guided angioplasty in a young patient, then I think DCB is certainly in play for both of these lesions. It's more in play the more diffuse the disease state gets. So I'll be interested to see what your IVUS or your OCT show.
Yeah, well, just by way of explanation, I'll hand over to my colleague who's much more experienced with DCB and multi-vessel. I would certainly image all three vessels. I would do a staged PCI, but for different reasons, we need to do a complete revascularization today. We don't want to put stents in because it's a diabetic in a young gentleman. And so we're going to go for a DCB strategy. And by doing that, do you want to explain our thoughts why we're not imaging and what we're looking for in terms of assessing if we've done a good job or not?
Okay, so the IVUS will show dissection. So
Wait, if you allow me, and what I will do in this case in my cath lab, I will stent the circumflex, focal stenting in the LAD regarding the BD or the BL branch with a relieved DCB or medical therapy for that. But that's what I will do practically in my cath lab.
Okay.
Let's see what you did now.
So generally, I don't use IVUS if I'm not using a stent. If I'm using a stent, yes, especially if it's LAD and multivessel or left main. So we did a pre-dilatation of the left circumflex or OM branch with a 2O balloon, and looks at the 2O balloon it's good size. And here is type B dissection, but not C because there is no hanging of dye after that. Next, so I landed 225 drug-coated balloon at 6 atmosphere for 90 seconds, 1.5 minutes. During that time, I monitored the patient's hemodynamics and the ECG. So no problem. So then this angiogram, as you see, it's a dissection right now. So the results, I'm very happy with the result in the left circumflex or OM. Then we turn our attention to the LAD. Next. So we use a 2O balloon. I go gradual with pre-dilatation because I don't know how much, I don't have a CT scan in this patient, and I'm not planning to do either. So I go with the 2O, 2.5C, the waist, and the go back. So this is 2.5 in the cross atmosphere here, and then 6 atmosphere for 30 seconds, then out. Next.
Yeah, so there's our picture after the 2.5 balloon.
Yeah, now the residual stenosis is, we set this residual stenosis to be acceptable less than 30, this is more than 30. I go with the vessel is good size vessel, so I'll go with the 3.0 millimeter balloon, and we'll dilate and see how it looks like, whether we need to stent or not. Stent, we need it in case of spiral dissection or residual stenosis more than 30%.
I'd just like
And
to.
this way, I assume this patient has diffuse disease, is diabetic. I don't have to stent across at the edge of a disease plaque, and I don't have to cross diagonal, which is very good size diagonal. So just DCB.
I know there's certainly debate as to what imaging you should do after the use of DCB, and I tend not to. I go by the dissection, but I would certainly image up front,
Yeah, so sizing.
Just
my practice.
Oh yeah, there's a comment from James here.
Yeah,
Go ahead, James.
just a comment about the diabetic pushback against stents. I think diabetes is a marker for diffuse disease, and I think that's why we don't get good results in them. But there are diabetics who have focal disease, and the evidence that that stents are not a good option there is much less strong. We see that in left main data where the disease is focal in diabetics and you get a good result mechanically, they get a good result clinically too. So I think it is often, we're seeing this example here in the LED, It's gone from looking like a very focal lesion to looking like a much more diffuse lesion post-stenting. And that's probably where the imaging adds that incremental data. It gives you plaque burden much more accurately. Khalid.
Absolutely, and to pick up on that point, James, in Syntax 2, diabetes was not a risk factor. So it was the complications of diabetes. So you didn't get a point if you had diabetes, but you did get points if you had kidney disease or peripheral vascular disease or markers of diabetic complication. And I agree with your point that this thing that everybody with diabetes can't have stents is not correct.
We have a comment from Dr. Khalid Shebi in the audience. Khalid?
I'm not sure why we're discussing DEB in the setting of focal disease in a large epicardial coronary. I mean, there was a recent Chinese study, I think it was presented at the ESC, which showed that clearly DS in this situation, where you're dealing with large epicardial coronaries and focal disease, DES is clearly superior to DEBs. Maybe in small or more diffuse disease there may be a role, but certainly not in focal disease in large epicardial coronary vessels.
I think that's a very valid point, and of course what we're trying to do is provide some education, and it's trying to see what can we do with drug-coated balloons, and what can we get away with. There's no doubt 4 or 5 years ago this gentleman was getting multiple stents. I'm more concerned about the stents in a 49-year-old per se than the diabetes.
Carlos?
So this is a 3O balloon.
Yeah, so Colm, the other way that has been advocated to understand whether you finish or not after a DCB is, and you have a pressure wire open, just basically put the pressure wire distally. If you have good flow, no translational pressure gradient, that's reassuring. If you remain with low flow, well, you have to put a stent. That's basically the way I see it. I think I fully agree with the comment that this is a case where it's focal, you should have beautiful landing zones. I think these are short stents in both the circumflex and the LAD, so I'm more in favor of putting stents than DCBs.
Yeah, I think very good points. We have the pressure wire open. The nice thing again about the volcano wires is it's very easy to reconnect and reuse, and you don't get the same drift as with the other wires, so we can certainly do that.
Yeah, and to be clear to Khalid's point, I think we have established a complementary use for DCBs in smaller vessels and bifurcations and so on, but there's no real convincing data in large epicardial vessels that there's even equivalence. As you said, the data to date is not supportive of use in large epicardial vessels.
But one thing is for certain, though, is that the physiology shows that the PDA lesion did not need treated, and there's no doubt that had this patient gone for surgery, they would have got a graft on that vessel. So I think that the physiology, multi-vessel physiology, is where I see its main advantage rather than single vessel physiology. If that makes sense.
And to be clear, the point I think is frequently missed is that there is a consequence to grafting vessels, particularly in young people. This gentleman's 49. This is the first stop on his revascularization journey. If he goes for bypass at 49, he's coming back in his early 60s with very complex disease. We know what bypass accelerates disease progression. And even at a year, the incidence of CTOs post-bypass is about 30%. So there is a consequence in grafting non-occlusive disease that we probably need to be more cognizant of.
And you know yourself, James, a lot of centres in the UK, they would be described as a diabetic multi-vessel, 3-vessel disease and mandatory surgery.
Owayed, you have 5 minutes to tell us you closed.
Okay. So now this is the preparation of the vessel. We did the 3.0 millimeter balloon to the mid-LAD, and there is no evidence of significant dissection. I'm planning to do drug-coated balloon to the LAD. Can we go to the other view, Elio, please? No, go 3 to 5. A little bit.
So in all your cases, you do DCP in focal lesion. You do physiology after, you do FFR, or CFR, IFR?
Yes, definitely. That's a very good option, because if the flow is, if FFR is 1 or FR is 1 and you don't have pressure gradient, that basically means that angioplasty was perfect. So that's a reassuring, I find.
Kevin and I are smiling because it's not an option for us.
It's not.
And we have now just one DCB available, and then the last 6 months, our institution lost $0.5 million by using DCBs in high restenosis patients. So we're doing them appropriately, but we can't sustain it from an institutional standpoint.
Yeah, the cost will be down in December because there's a change in the payment, so this will be more of an option for us in the near term. But in the U.S., we have very little experience with it, so I think, I watch with interest cases like this where colleagues that have been using this modality more have experience. But I have watched with some interest the lack of good outcomes if the FFR, IFR is abnormal at the end of a DCB in an epicardial. In small diffuse arteries, we have no option. That's actually where we'll spend the money in our current practice. But in this particular case, by my look at the angiogram, it looks like there's substantial recoil. And so the physiology here will be critical. And it looks to me like it's going to probably need a stent if you can't address that recoil in some way. Moving to a cutting balloon, a scoring balloon, other ways to potentially mitigate the recoil could be done. Whether that helps facilitate entry of drug into the wall and potentiates a DCB activity is something that's under study. But at this point, I'm a little suspect that the recoil in this particular example with a big epicardial LED will have a good outcome with image-guided PCI, be looking to stent it unless we improve that potentially or show that the pressure downstream is normalized.
You hold it?
Yeah, I agree with those points, Kevin. It is looking a bit more, to my mind, like this will get a stent, but we'll do the DCB and we will check the physiology just. So there's a 325.
There is resistance here.
So Wade, you heard the comment, there is a recoil likely there. So what's your next step now?
Yeah, let me take this out. Recoil?
Are you happy with the LED
No.
after?
Yes, I'm happy. See, the residual stenosis is less than 30% for me. Go to the iliocranial.
In the iliocranial,
Yeah.
we thought it's.
Look. Usually iliocranial overestimate the overestimate the stenosis, and look at it. It's less than 30%.
Yeah, well, you have the pressure wire on the table, so basically, eyeballing angiograms, everybody will say a different number in this room.
So you will assure us with physiology then.
Back into the guide. Bring that back into the guide. Can we go live on the pressure wire, please? Can we go live on the pressure wire? So can we do an IFR? And record. Hold record, yep. So Carlos, that is an IFR just after that preparation.
Introduced from 0.5 to 0.9.
Are you happy with that, or we're going to give a little bit of nitrocine?
Well, that's a good discussion to have, but it's a young patient. I think you can achieve better flow than that. You're still in the ischemic threshold, so and I would honestly put a DS.
I mean, for this one, we're biased by our practice, but I would stint the LED. Recoil bothers me, and the IFR 0.89, I think you can do better in a person that's 40 years old.
James, what do you do?
Yeah, I think I would do adenosine here, just understand what the FFR is at. But I mean, we shouldn't be too negative about that result. I mean, it's a delta benefit. We know the delta benefit strongly predicts outcome in terms of symptoms, but we don't know the relationship of this gentleman's symptoms to his coronary disease. I would suggest there's probably a fair degree of discordance there. But I would say, even though we've been slightly negative about the use of DCBs in this scenario, actually this is a decent physiological result, not perfect, but decent.
Kevin?
Yeah, I think, I've watched, the design of the DEFINE GPS study is looking to get people to normalized IFRs well north of 0.93, because that's where the outcomes become more bulletproof from a, really durability standpoint. I think James's point about FFR to get more information, especially in the LED, is helpful. In this particular case, I do rely on our experience with an image-guided LED stent in a large epicardial with 100% expansion. The event rates there are quite low. And so that's the modality I'm most comfortable with, because that's our experience, not having had use of DCB in these settings in the United States so far. And so with the outcome certain or more certain with a stent that's well placed, that would be my bias. But I am intrigued and respect this type of modality as a way to progress practice and potentially not commit the patient to a prosthetic, which can cause problems many years down the road.
So James just point to the screen and said, look at the FFR. That's not the FFR. That's the wedge pressure in the coronary. So basically, they're inflating the balloon. This is a beautiful demonstration of what is the wedge in the LAD. So you hear here it's not bad. I think it's around 50, 23. That's good.
It's a nice feature of this wire, Carlos, isn't it? You can get these pressures, you don't get the drift. So I actually think it's a really nice wire to use.
So what size the drug-loading balloon you had, Owayed?
This is essential. It's paclitaxel drug coated balloon.
325 by 20.
Sorry, what's the size?
325 by 20.
Okay, is this one?
Sorry, we cannot hear that. 225, you said?
What is this? 325 by 20. We need to write this one. You got it, Khalid?
Yeah.
So we need to write it.
Okay. Okay. We have to conclude here. I got from the.
So I'll show you the image right now.
Okay. 1 minute,
So
so we have to conclude. People are hungry and they need to go to prayer.
Khalid, you saw the angiogram of the left circle, and we'll show you now the angiogram of the LAD. Okay.
But this is a good case for discussion what to do with the focal region, epicardial, and young guy also, and multivessel disease.
Do an angiogram, and we'll give you another.
No, do the IFR because contrast will make it worse.
Okay, can we do our
IFR?
IFR record, please? .89.
Put it on. Okay. Ready? Okay, go cranial.
3 to 5. Difficult to hear. So wait, we couldn't hear the diameter of the balloon. Was 225 or 325?
No, 3 to 5.
325, okay.
3 to 5. Yeah, open. Sorry. And now the final angio, because of the left multiple contrast injection, it might increase the dissection if there is a dissection. No, we're finished right now from the left system, and we have achieved the drug-coated balloon in both sides, LAD and left circumflex, and there was a spasm in the middle LAD. We need to do probably an answer for that. And you see here the diagonal also painted, and both of them they have minimal dissection.
So, and what's your plan for the BL branch? What's the medical therapy or DCB?
No, BL, the PL we can do it's a small size. We can do FFR as well. But the BDA.
BDA branch, sub-branches for DCB is the plan.
Yeah, DCB is the plan for the BDA branch.
Okay. Okay, Owayed, thank you very much. Thank you for you and your team and for this great case, great discussion. Final comment from the panels. Start with James, so we can conclude. Final comment about this case.
Yeah, I mean, it was a great session. I think a lot of the learning points in Carlos's talk came out in the live session, which is what you want to see. I think there's an emerging use for DCBs, but we don't know quite in what patients yet. There will be an extended use criteria potentially, but the data's got to support that direction of travel. And you can see the value of physiology in real-time revascularization. I thought that was the take-home message for me.
Okay, Carlos?
I think that for me, the integration of all these technologies is really helping us taking decisions in the lab. We have seen in the case the use of physiology in this way. I think it really complements the way that we look at the angiogram and take decisions. So for me, that's the take-home message.
Yeah, I agree that. Now I'd add on this case that's a perfect example where I think OCT would have been very helpful. So you can't do everything in a live case, but in this case, especially because there was an acute coronary syndrome, we still don't know for sure what the culprit was.
Yeah, I appreciate, physiology is an indication of what to treat, whether to treat. And gradient pullback, is potentially a way to understand where the major pressure drops are. And I really celebrate the fact that this case was used for teaching in a live case scenario, because I think the use of DCBs in this setting is new, it's provocative. Many are working to develop data, and I think it's potential where we're going to be going in the future. And so it's progressive use of this technology in a way where I'm happy to learn from colleagues that have had access to it longer than we have.
Thank you very much. Because of the time, we have to conclude. Thank you very much. And I think there is a lunch on the first floor and for the break. Thank you, and we resume back in 45 minutes. Thank you.